Assalamu alaikum everyone. My name is Dr. Adnan and my moderator will be Dr. Noman. Today our topic of discussion will be benign renal masses. These are my learning objectives: understanding and the spectrum of benign renal masses, review diagnostic approaches, summarize the management strategies. Introduction to the benign renal masses. Benign renal masses are increasingly detected due to the routine imaging. 20% of the suspected renal cell carcinoma masses are benign. Benign renal masses tumors represents heterogeneous groups. Classification of benign renal tumors: number 1, renal cysts, oncocytoma, angiomyolipoma, papillary and metanephric adenoma, cystic nephroma, and MESTs, mixed embryonal and stromal tumors, leiomyoma. Let's start with the renal cyst. Renal cyst, most common benign renal entity affecting up to 10% of the population. Risk factors include age, male sex, hypertension, and renal dysfunction. Causes may be sporadic, acquired cystic kidney disease, genetic autosomal dominant polycystic kidney disease, or the autosomal recessive polycystic kidney disease. Genetic forms, autosomal dominant and autosomal recessive, are the main inherited causes, with autosomal dominant linked to the PKD1 and PKD2 mutations affecting cilia function and calcium signaling. Pathophysiology of autosomal dominant polycystic kidney disease. Cyst formation begins as a diverticula on the tubules that detach and enlarge. Growth is progressive, leading to the enlarged kidneys, renal insufficiency, and systemic cysts, hepatic and pancreatic. Diagnosis of autosomal dominant polycystic kidney disease based on the cyst numbers and the age. 2 or more cysts before the 30 years of age, are the 2 or more than 2 cysts per kidney between the 30 and 59 years of age, and 4 or more than 4 cysts per kidney at the age of 60 or plus. Acquired cystic kidney disease develops in patients with the chronic and stage renal diseases, is strongly associated with the dialysis duration up to 80% after the 10 years of dialysis, and carries a risk of RCC approximately 7% after the 10 years.
Just a moment. You see, this very statement that acquired cystic kidney disease is something that relates to dialysis and chronic kidney disease is something which has been observed in the last 30 years. And this has put a kind of alarm in all the communities of urologists and nephrologists, because that carries again something which is like a turnover into RCC. And as written here, it's like 7% after 10 years of dialysis. So earlier in our setup also, we have seen patients chronically ill, chronically on dialysis, just because of the reason the transplant activity was not proper. So patient has to wait for a very long time. And this is something which we have seen right before our own eyes. If and I assume that all of us are quite observant, we have seen patients coming with simple cyst. They converge into something called a cyst which is complex, and then it progresses towards something which is like RCC. So you see, whenever you get hold of a patient who has got a cyst and who is on a dialysis or who is on chronic kidney disease, you must be pretty sure that there is something which is going on ominously. You must keep that person, because that will create a kind of a challenge, because that patient will not be for a transplant unless and until the cancer part is taken care of properly. You see, so you end up with a patient who cannot be on a transplant list, who is on a chronic dialysis program, and who has got a tumor. So this compounds the whole picture. And there is no one who can do justice with these patients unless and until that person who happens to be a urologist who knows everything about this concept.
Evolution. Most renal cysts are discovered incidentally, but some cause pain, mass effect, hematuria, or the pulmonary symptoms. And autosomal dominant polycystic kidney disease, imaging with ultrasound, CT, or MRI is the key evolution. On the imaging features, simple cysts show smooth walls, sharp outlines, no internal echoes on ultrasound, and leg enhancement on the CT or MRI. MRI is useful for the hyperdense cyst, but may overestimate wall thickness. Bosniak type 1, Bosniak classification of renal cyst, including Bosniak 1, 2, 2F, 3, and 4. Bosniak 1, simple cyst with a hairline, thin wall contain the septa, calcifications, or the solid component. It measures water density in household units and does not enhance with the intravenous administration of contrast agent. In Bosniak 2, cyst may contain a few hairline thin septa and fine calcifications, or a short segment of slightly thickened calcification may be present in the wall or septa. Uniformly high attenuation lesion of less than 3 centimeters, so-called high-density cysts, are well marginated and do not enhance with the intravenous administration of the contrast agent. Bosniak 2F cysts may contain multiple hairline thin septa or the minimal smooth thickening of their wall or septa. Their wall or septa may contain calcifications that may be thick and nodular, but no measurable contrast enhancement is present. These lesions are typically well marginated, totally enhancing high attenuation renal lesions of 3 or more than 3 centimeters are also included in this category. Bosniak 3 are the intermediate cystic masses having thickened, irregular or the smooth walls or the septa on which measurable contrast enhancement is present. Bosniak 4, clearly malignant cystic masses can have all the criteria of category 3, but also contains enhancing soft tissue component.
Right. So again, I just want to intrude here. If you go through Bosniak 1 till Bosniak 4, what you are seeing is actually not only the septal defect, but also the increase in the diameter of the septa, as well as increase in the angularity of the septa. For instance, it goes like this from acute angle to obtuse angle to loss of angle. You go to number 1 picture, this one. So you see, in this one there is no septa. In 2, there is a septa with an acute angle. Rather, it's a perpendicular 90-degree angle. Going to 3, the angle becomes acute, maybe 60 degrees. You go to 3, the angle is lost. You go to 4, everything is lost. You see, the septa is thickened, the margination is proper, it is contrast enhanced, and you see there is a transition in process. Again, this is an observation which has been there for the past 30 years, but this acuteness of angle and the loss of angle was not there. It came into being just because of the reason that we have now good imaging technique. We have got CT scan with contrast for Bosniak classification. Bosniak classification is never done on ultrasound. You can do it on ultrasound, but that is contrast enhanced ultrasound, which is not available in Pakistan still. So either on contrast enhanced CT or MRI. So this is what is all about Bosniak classification.
Whenever a patient visits an OPD clinic and there is a cyst in the kidney on ultrasound, what is the next step we do? Over R5s, Maluk, Uzma. तो जल्दी बताएं ना, मतलब cyst आई आपके पास, आप अल्ट्रासाउंड में क्या देखेंगे, क्या रेड फ्लैग साइंस क्या होंगे?
If it is a simple cyst, then mostly we ask patient to follow monthly, 6 monthly, 3 monthly, and we'll look for the size increment and counsel patient.
Maluk?
If there is a suspicion of calcifications or the size of cyst is increasing, the increased size can offer the CT scan to the patient and follow accordingly.
सबसे पहले पेशेंट हमारे पास आता है ना, we have to see the symptoms and signs, why is presented, if it's a pain or flank mass or hematuria. Then ultrasound पे हमें नजर आ जाता है कि there is echogenicity inside the cyst, material तो नहीं, कोई soft tissue तो नहीं. फिर हम डिसाइड करते हैं this is one cyst or multiple cyst, patient is एपिकेडी और patient is having just a simple renal cyst. उसको डिसाइड करने के बाद फिर हम step further जाते हैं. If there is any suspicion of malignancy, if we have the knowledge of Bosnian classification, what just told us about, we will order CT renal triphasic with 3 phases. We will see the enhancement, we will see the wall of the cyst, we will see what is the internal components. How many septa are there? Are septa are enhancing on the contrast, or there are any calcification? And this Bosniak classification has some of the. This is just like a risk stratification. It is a 1, 2, 2F, or 3, or it depends. If it is a 1, there is no chances of malignancy, but we have to follow. In 2F, F means follow. We have to follow this patient. 3 and 4, we have to keenly follow the patient, or you have to do something like curative. You have to excise, ablate, or remove the whole kidney just to keep the patient. And the second thing is that these small little masses and these cysts, they are associated with syndromes. If it is a female specifically, they are mostly associated with syndromes. If patient is having this cyst also and with hemoptysis, the diagnosis will be different. If patient has something like complex masses, MEST syndrome, or we have to evaluate all these things. We can evaluate this after we know about what is the significance and what are the associations genetically and pathophysiologically of these small little masses, these cysts with other syndromes. After that, we can evaluate. If we don't have the knowledge of the basic renal cyst, will not have any suspicion of any malignancy or any other syndromic evaluation of that cyst, and we will lose our patient very soon.
So the funny thing about this cyst wall is it is not homogeneous. For instance, what you see on ultrasound or CT scan, maybe it's a simple cyst and you order for marsupialization. But whenever you go for marsupialization, make it a policy that the cyst wall has to be sent for frozen section. You wait for a minute or 2 or maybe 5 minutes so that the report comes in, and then you are pretty sure that there is no malignancy. Sometimes what happens is the cyst wall has got one area which is non-malignant, the other area which is turning into malignancy. And that happens to me personally in 2 or 3 cases also. So marsupialization is something which is easier to do. It is done laparoscopically. But again, the fallacy is you have to send the cyst wall. Never be sure that this is something which I have seen on CT or ultrasound, and it looks like there is no septa, so there is no malignancy. The septa can go with malignancy, septa cannot go with malignancy. Is a cyst. It is the analogy is like a bladder. The bladder wall is not homogeneous. Sometimes one area is turning into carcinoma in situ, the other area has got a polyp, which is like PTA. So things like this can happen in the cyst also.
Management of renal cyst depends on the risk of malignancy and associated symptoms. For Bosniak 1 and 2, no therapy or the follow-up is required. And for Bosniak 2F, active surveillance up to 5 years. 5 years is there. And for the Bosniak 3 and 4, the surgical resection or ablation is there. And outside of the malignancy, for associated symptoms, management can be include aspiration, cyst decortication, cyst resection, sclerotherapy, arterial embolization, and even nephrectomy.
What does ablation mean over here for 3 and 4 cysts, Dr. Numan?
These are locally local management techniques, like you do the ultrasound guided ablation, you use the heat, or you use the waves to ablate. Ablate means to dissolve that tissue with some material. There are 2 things. You can do the cryotherapy, you can do the micro high frequency wave ablations. So this concept is just for the small renal masses. Like previously it was for the prostate and in the kidney. It's the same technique, but the reason is that you distort the basic structure, DNA structure of the kidney, and you made that cell die. It will be there.
Dr. Sad, can we perform ablation in a cystic disease? This is my query. Because in a solid mass, yes, there was a patient who had a lot of recurrence from the right side to thorax and then to the left kidney. We did partial for that solitary kidney, and then the patient developed multiple small masses. And it astonished me that the patient went for radiofrequency ablation, and now the patient is tumor free. I think so. She doesn't have any tumor on the current CT scan. So ablation works like miracle for in that case. So in a cystic case, can we perform it or?
You see, again, some of the basics of physics, you have to go back to FSC. Whenever you are dealing with anything like a energy source, there has to be a wall that reflects to and fro. That wall has to be something which absorbs a little bit and then throw out or reflect most of it. And in that process, there is something which is known as absorption of the energy. Maybe the energy source is ultrasound, high frequency ultrasound. Maybe it is a cold wave, which is like in cryotherapy, greater than or lesser than minus 70 degrees Celsius, or it might be hyperthermia, which is actually the phenomena behind electromagnetic radiation, and one of them is radiofrequency ablation. You see, if there is a fluid medium, it absorbs everything. It will not throw out any energy source towards the transmitter. So if everything is absorbed, how come the ablation process actually starts? Ablation starts when the energy is absorbed and it is reflected to and fro. So that to and fro movement which actually disrupt the tissue. There is no disruption if there is a fluid. Fluid will absorb everything.
I have got a query, sir.
नहीं होगा.
For ablation, if you are talking about the suspected malignant cyst, you need a biopsy prior to applying this mode of treatment. Yes, we can do for simple cyst if you are sure that it's a simple. I have questioned that how you gonna take the biopsy from the cyst?
It
And
will
if you are
come.
suspecting malignancy and you are talking about radiofrequency ablation and cryoablation.
ये बिल्कुल आपने सही कहा, इसलिए कि पहले हम इसको डिस्कस कर चुके थे कि एज अ रूल वी शुड नॉट डू अवे विद समथिंग कॉल्ड फ्रोजन सेक्शन. आप चाहे उसकी मार्सुलाइजेशन कर रहे हो, चाहे आप उसकी एक्ससिशन कर रहे हो, एब्लेशन कर रहे हो, द फर्स्ट थिंग इज यू हैव टू टेक बायोप्सी फ्रॉम मल्टीपल पॉइंट्स, फ्रॉम द सिस्ट बेस, फ्रॉम द सिस्ट फ्लोर, फ्रॉम द सिस्ट रूफ, rather than just de-roofing the cyst and let nature be healing process taken over by nature. So there has to be a biopsy. Yasir is quite right. And biopsy cannot happen when you do ablation like radiofrequency. Either you do biopsy first and you do a radiofrequency. What radiofrequency does is it first evaporates all the fluid medium which is inside, and then it sort of coagulates the cyst wall. But again, the problem is it will not stop at that point. It will go into the normal tissue of the kidney. So radiofrequency, I haven't seen any article regarding cyst ablation done by radiofrequency. Radiofrequency is for solid tumors,
Yes.
not for cystic tumors.
Second is the oncocytoma. This is the most common benign enhancing renal mass, accounting for up to 50% of the renal tumors of less than 4 centimeter. Although once questioned, genetic study confirms its benign nature, with the rare reports of metastasis likely misclassified chromophobe RCC. They mimic the eosinophilic chromophobe RCC and succinate deficient dehydrogenase deficient RCC and papillary RCC, grossly mahogany brown with the possible as a central scar. Histology shows the eosinophilic cells, mitochondria-rich nest tubules, rare mitocytosis may extend into the perirenal fat and or vein, but unlike RCC, this has no prognostic impact. The diagnosis is typical morphological, often sufficient. Variants require ISUP recommends CK7, rare and oncocytoma, diffuse and chromophobe RCC, CD117, and positive and oncocytoma, Vimentin and oncocytoma positive and RCC, and plus kidney specific cadherin. Genetic and syndrome associated with the loss of chromosome 1, XY, 14 and 21, 11q, 13 rearrangement linked with the Bird-Hogg-Dubé syndrome, which is autosomal dominant disorder. There is a mutation in the chromosome 17 on folliculin gene, which is associated with the folliculosis, lung cyst, folliculomas, RCC oncocytomas, and oncocytosis. Evaluation is usually an incidental unilateral renal mass. 5% occurs bilaterally. Imaging includes hypervascularity and the central scarring. On the CT MRI suggest oncocytoma, but are not diagnostic. 99M technetium sestami B spectrum CT shows high sensitivity 87.5% and specificity 95.2%. Diagnosis is definitive post-operative. Renal mass biopsy has limited accuracy. In this, on the left side, ultrasound image showing a 4 centimeter well circumcised hypoechoic mass in the with the thick arrows with showing the central hyperechoic stellate scar and the thin arrows on the right side. And the B and C contrast enhanced dynamic CT images demonstrate a heterogeneous enhancing mass with the delayed enhancement corresponding to the central scar thin arrows. The mass shows highly and less enhanced segments on the corticomedullary face, which is inverted on early excretory face image. This segmental enhancement inversion pattern is commonly seen in oncocytoma. Management strategy standard approaches most oncocytomas are treated with the surgery due to RCC concern, followed by observation. Active surveillance safe when diagnosis is biopsy based, low growth rate of 0.14 mm per year versus chromophobe RCC 0.38 centimeter per year with the excellent 5-year survival rate. When intervention is needed, use a nephron sparing option, ablation or partial nephrectomy whenever feasible. Angiomyolipoma, the third one, benign renal tumor of vessels, muscle, and fat, often linked with the tuberous sclerosis complex, and leiomyoma, and more common in middle-aged women. TSC and LM association often linked with the ML is often linked with the tuberous sclerosis complex, which has epilepsy, neurocutaneous features, or the angioleiomyomatosis, lung cyst, chylus effusions, genetic TSC1 and TSC2 gene mutations, on which hamartin and tuberculin interact with each other, results in the inhibitor of mammalian target of rapamycin, mTOR activation, which leads to the increased protein synthesis, cell growth, and angiogenesis. Cell of origin derived from perivesical epithelioid cells, picomas, tumors composed of abnormal vessels, smooth muscles, and adipose tissues. Pathophysiology variants, epithelioid angiomyolipoma, low-fat epithelioid cells, ATP and necrosis can behave aggressively with the reported metastasis. Differential diagnosis can mimic with the RCC or the sarcomas. IHC HMB45, Milan A hormone receptors aids in confirmation. Often incidental on imaging, up to 15% present with the Underlich syndrome, which is presented with the spontaneous retroperitoneal hemorrhage. Pregnancy increases the rupture risk due to the hormonal receptor positivity. Diagnosis on the radiology, ultrasound shows a well-defined echogenic with the posterior acoustic shadowing. However, this is not a pathognomic of AML. RCC may have the same appearance, so further imaging is needed. In the setting of tuberous sclerosis, there may be so numerous that the entire kidney is affected, appearing echogenic with the loss of corticomedullary differentiation. On the CT, the presence of fat with the Hounsfield unit of 10 or less is considered diagnostic. Up to 5% AML are fat poor, especially in tuberous sclerosis. Absence of calcification favors diagnosis of AML. On the MRI, excellent diagnostic modality for fat-containing lesion. Two main set of sequences are implied, T1 and T2 hyperintensity enhancement on the gadolinium administration, hypointense on T1, fat suppressed sequences and in-phase and out-of-phase. Imaging generate India-Ink artifact between fat and non-fat component. This can occur at interference of kidney and mass or between fat and non-fat component. Although the diagnosis can be confidently made on the imaging, in most circumstances, fat-poor AML, which resembles RCC, fat-containing RCC, and liposarcomas are unique situations in which the diagnosis can be problematic on imaging. When fat-poor AML is considered, percutaneous biopsy has been successful in determining the diagnosis. Approximately 4 to 14% of AML do not contain radiographically identifiable fat and appear similar to the RCC on standard imaging. In that case, MRI is helpful.
Of all the benign lesions of kidney, AML is something which is quite often frequently diagnosed condition. But one thing that that slips out of our minds is the turnover of AML into malignancy somewhere down the line. So it is hematoma, but it is not hematoma proper. It is in transition. That means it can change its character or identity very soon if you follow these patients. So they might be having a benign course of natural history in the initial stages, but later in life it becomes tumorous. So whenever AML is there in your follow-up, please do consider this patient as something with, again, a red flag sign. You keep that patient under close surveillance, meaning to say every 6 months or maybe a year, and don't shrug off that आपको तो आने की जरूरत नहीं है because you have got AML. जब आपको तकलीफ हो तो आइएगा नहीं, आप वैसे भी आइएगा.
There is a correlation between pregnancy and AML. We have recently seen in past year 2 or 3 cases with this Wonderlich syndrome. Why in female, and if in female, what are the associations between Wonderlich syndrome or retroperitoneal hemorrhage of this AML during pregnancy? Childbearing rate. Yeah.
Due to the hormonal influences, the size may increase to an extent that it may end up into the bleeding.
Already mentioned in the slides, in female patient, these AML, they have the estrogen progesterone receptors. So in pregnancy, to make the pregnancy stable, there is a high surge of progesterone or estrogen. So whenever in a childbearing age, whenever there is a fluctuation of these hormones, they can make these blood vessels and these angiomyolipoma, they grow bigger. When they grow bigger, this is basically surrounds or involve, this is basically from the blood vessels in the kidney. So whenever there is a growth, the permeability will be increased. The vessel permeability will increase and the increased angiogenesis will be there. And when the androgens are increased in the childbearing age or in the pregnancy, they can rupture. When they can rupture, the patient can present in the shock status in the emergency or in the ward directly due to the bleeding in retroperitoneum. Patient is not having any hematuria, but she is in shock because of the massive bleed. Whenever this case is in our setting, we do explore the patient. We have to end up with in the nephrectomy. And do consider that these AMLs in pregnant lady, in childbearing age, in female, they are not unilateral. Mostly they are bilateral. So you have to make sure that which kidney is bleeding and which is stable. So you have this is a very complicated case to make the patient from renal sparing surgery to make him the ANF free with the child inside our body. So we have 2-3 cases we have done recently. Dr. Haris, Dr. Riaz, they are more familiar. One was done in this OT and one was done in old OT. So, and these AMLs are associated with syndromic. Like you have seen tuberous sclerosis complex. We have 2-3 cases in our follow-up, more than 2-3 cases. They have particular features like perianal fibromas. They have scars, stellate signs on the back. They have 8 or 9 features. In the written book, you can see all of them in the patient. But whenever put on the mTOR therapy, like everolimus, they are completely resolved. They have the epilepsy. Why? Because they have these type of lesions in the brain also, in the lungs, in the pancreas, in the duodenum, in the seminal vesicles also. So you have to study about it before proceeding towards the patient, just to follow up for the AML. Now you have to follow up the patient and symptoms, every symptom from head to toe, and you have to examine the whole body.
Now, in the past, we have got one case, and that was one of those cases which in our unit, SIUT was the very first one. And that case came with a kind of a huge kidney on one side and slightly lesser huge kidney on the other side. And both the kidneys were actually bleeding at the same moment. So the patient has to be operated the same day, the same night, rather, and patient became anephric. Later, one of the kidneys came out to have a tumorous kidney, and the patient remained on that follow-up of dialysis and things like that. But the lady has got a facial appearance of tuberous sclerosis. So those slides were again sent through the meticulous examination by other people. And the actual cause was tuberous sclerosis, and it was AML with a slight bit of component of RCC coming into the picture, also in one of the kidneys in the wall. So what happened was that patient kept on with us for 2-3 years till such time that we were pretty sure that there is no more tumors in the body and the patient can be on a transplant list. So a transplant was done, and then that lady is still with us, and she is on everolimus. So one drug hits 2 targets. The target number one is the transplant itself, because everolimus is something which is like an immunosuppressive drug for the kidney to be accepted by the body. And the second target was tuberous sclerosis, and then her face and the facial lesions were gone out, and she became as normal as anyone. So now her tuberous sclerosis is taken care of by the same drug as transplant.
AML patient can be presented panless hematuria, palpable mass, or as a Wanderlich syndrome. Management depends on if the patient is management is active surveillance. If the patient is asymptomatic solitary tumor, or the tumor is less than 4 centimeter and the aneurysm of less than 5 mm. Management options in symptomatic patients can be surgery, nephron sparing preferred, curative and most sporadic cases, ablation, radiofrequency ablation, cryo, small series, acceptable safety, and embolization useful in hemorrhage size reduction, but frequent recurrence or the reintervention is needed. And the systemic therapy, mTOR inhibitors, everolimus, or the sirolimus, effective in TSC and AM, associated the ML with durable. This is a flowchart for the management of AML. Fat-containing lesion and either differential diagnosis is made, and after the proper diagnosis, biopsy or MRI, RCC or other tumor, they are treated accordingly. If the diagnosis made as renal AML, it is again classified into the three categories: symptomatic, asymptomatic, or the spontaneous retroperitoneal hemorrhage. If the patient has a spontaneous retroperitoneal hemorrhage, then it is treated with the hemorrhagic shock management, selective arterial. If it is asymptomatic or the oligoasymptomatic, the further conditions are there. If the lesion is more than 6 centimeter in the diameter and the aneurysm of more than 5 mm in diameter, if the growth of ML is more than 0.25 centimeter per year, and the woman is in the childbearing age or the pregnant, then again the active treatment should be done. And asymptomatic patients, other conditions, the subtypes of the treatment depends on the subtypes. Subtypes, if it is associated with the tuberous sclerosis complex related, if the tumor is more than 3 centimeter, everolimus is given and follow-up is done after 1 to 3 years with the MRI. If the subtype is epithelioid tumor, treatment is as RCC. If the subtype is a sporadic, the active surveillance is done and the follow-up with the ultrasound or CT at the 6 months, then later manually. If the patient is with the ML and symptomatic, active treatment is done with the selective arterial embolization, nephron sparing surgery, and the radical nephrectomy or the thermal ablation. Third one is a papillary adenoma, and definition is a circumscribed low-grade lesion of less than 0.5 centimeter. Epidemiology is increased with the male, age, male, and stage renal disease, acquired cystic kidney disease, sporadic, and the hereditary papillary RCC. Histology, tubular, papillary, tubulopapillary, uniform, benign nuclei, and the resembles papillary RCC. Significance often multifocal, shares HCAMA-CR positive and cytogenic changes, trisomy 717 with the papillary RCC, considerable possible pre-malignant precursor. Clinical context usually incidental and less than 1 centimeter, diagnosed with the RCC specimens. Management, no directed therapy, observation appropriate. Metanephric adenoma, rare, 0.2% of the renal masses, more common in females, peak 5th decade. Presentation is in 50% incidental, may cause flank pain, hematuria, mass are the polycythemia with the increased erythropoietin secretion. Grass are the histology, well circumcised and mass uniform, bland cells with the SNR, tubulopapillary or the glomeruloid pattern, no atypia or the necrosis. Immunoprofile and WT1 positive, CD57 positive, AMA-CR negative, CK7 and EMA negative has differentiate from papillary RCC and adenoma. Genetic often shows trisomy 7, 17, 19 may share a spectrum with the papillary. Management of the prognosis is a partial nephrectomy or the ablation. Biopsy can prevent or treatment, excellent outcome. Metastasis rare, extremely rare. Cystic nephroma, rare benign renal tumor of the bimodal distribution, boys 2 to 3 years, and adult woman 4th and 5th decade. Radiology, solitary central multilocular cystic mass with a septal enhancement plus minus calcifications. Differential in children mimics with the Williams tumor, and adults mimics cystic clear cell RCC. Histology, encapsulated cyst lined by cuboidal horn with the collagenous spindle cell stroma. Immunoprofile, epithelial cytokeratin positive, stroma CD10 positive, retinal inhibitin, ER and PR positive. Management is a children, radical nephrectomy cannot be ruled out with Williams. Adult, often resection, benign but rare malignant transformation reported. Mixed epithelial and stromal tumors, epidemiology, benign renal tumors, mostly in perimenopausal women, often with estrogen exposure, rare in men after long-term hormonal therapy. Pathology or the radiology appears as a complex cyst, Bosniak 3-4, mimicking RCC, grossly 6 centimeter, encapsulated solid and cystic with a mixed epithelial, cuboidal, columnar, urothelial, and stromal spindle cells, smooth muscles, and collagen elements. ERPR positive, CK7 positive. Prognosis management usually resected due to the RCC mimicry. A malignant stromal transformation reported associated with the poor outcome. Leiomyoma, epidemiology, and the sites rare smooth muscles, 0.29% of the renal masses, more common in women 2:1 ratio. Most often arises from the renal capsule but can occur anywhere in the urinary tract. Imagine small, well circumscribed exophytic masses, hyperdense or non-CT with the hyper enhancement. Histology shows the blend spindle cells with the and fascicles without atopia necrosis. Stents positive for Manton, Desmin, Caldesmin, negative for Melon A, adipose tissues, helps distinguish from AML. Management often benign and slow growing nephron sparing surgery preferred when diagnosis uncertain, earlier asymptomatic. Thank you.
So the small renal masses are very particular in diagnosing and managing. So do remember the key points whenever the patient comes with small renal masses. All masses which come in this presentation, they are small renal masses. You have to see the patient presentation, symptoms, signs, and his sex. He's either male, female, if female childbearing age, or she is pregnant or not. You have to see the contralateral kidney and then the size of mass. If the mass is having a soft tissue component or it is a septa. You have to distinguish from cyst, and then according to cyst follow-up. If this is a mass, you have to know, you have to get the knowledge regarding the hereditary masses associated with renal masses. So hereditary all syndrome, but Hoch-Dubé syndrome, hereditary leiomyoma, papillary RCC, this tuberous sclerosis complex, and all other, you have to get the knowledge of these before proceeding towards the patient. So everybody, I hope everybody will read this, and the homework is that we have to know when to do the renal mass biopsy. So we'll come in next presentation.